Question 2 focuses on the size of the QRS complex and asks the question, is the QRS complex a normal size? And then it gives you direction on what is a normal size. Is the negative part of the QRS complex the Q wave in lead 1, V1, or lead V2, plus the positive part of the QRS complex, or R wave, in lead V5 or V6, less than 35 millimeters? If the answer to this question is yes, the QRS complex is normal in size, then you will move on to the next question. If the answer to this question is no, meaning that the QRS complexes are excessively large, then you probably have left ventricular hypertrophy, and we can no longer use this algorithm to diagnose STEMI. So let's talk a little bit more about why we're asking this question. Okay? Why are we asking this question, you might ask? We are considering the presence of LVH, or left ventricular hypertrophy pattern. And why is the LVH pattern important? Approximately 80% of patients that have the LVH pattern will also demonstrate significant ST segment elevation and ST segment depression. These ST segment changes are not always related to STEMI and can confuse the unwary and unschooled ECG interpreter to diagnose infarction when it is not present. So here's a 12-lead ECG of a patient that has the LVH pattern. Okay? They are not having a heart attack, even though significant ST segment elevation is present, as you can see in V2, V3, as well as ST depression in V4, V5, V6, and leads 1 and AVL. Because of the excessively large QRS complexes in V1 and V6, among many others, when you add these values up on a typical ECG with grids, you can see that it is more than 35 millimeters, meaning that this person has the LVH by voltage pattern and that these ST segment changes are likely due to the LVH pattern. This circle highlights the important areas on this ECG demonstrating the excessively large QRS complexes. A blow-up of this ECG, looking at leads V1 and V2 as well as V5 and V6, demonstrates how we would add up the QRS complex sizes. The negative part of the QRS complex in V1 or V2 plus the positive part of the QRS complex in lead V5 or V6. Importantly, you don't use V1 and V2 or V5 and V6. Use one lead from each of these groupings. If the QRS complex size is greater than 35 millimeters, then you have a patient who probably has the LVH pattern and can have ST segment changes, both elevation and depression, that are not related to acute myocardial infarction or STEMI. The ST segment T-wave changes seen in LVH can mimic or confuse the unwary interpreter to think that STEMI is present when in fact it is not. 80% of patients with this ECG pattern will have ST segment changes that are not indicative of ACS, and that's why it's important to use this algorithm so we can exclude this finding from consideration. So, after we've asked the question in question 2, we have ruled out excessively large QRS complexes, which means that we have removed LVH as an entity. If LVH is not present on this ECG, then any ST segment and T-wave changes are not related to LVH either. So we move on to question 3 now, which looks at the QRS complex in a different way. Okay, now we've moved on to question number 3, which considers the width of the QRS complex in this algorithm. We've decided that a QRS complex less than 0.12 seconds is normal. Any QRS complex greater than 0.12 seconds in width will be considered abnormal for this algorithm. Importantly, anywhere in this algorithm or slide set, if you encounter a QRS complex width of anything other than 0.12 seconds, please disregard that and use less than 0.12 seconds as the normal QRS complex width. Why are we considering the QRS complex width in this setting? Certain ECG patterns that are abnormal will have a widened QRS complex. These include left bundle branch block pattern, as well as right bundle branch block pattern and ventricular paced rhythms. As we've stated before with respect to the LVH pattern, these patterns also will produce new ST segment and T wave abnormalities that are the new normal for these patterns and not indicative of underlying ST segment change due to acute myocardial infarction. You can see here the two examples. In the upper example, left bundle branch block pattern, and in the lower example, ventricular pace pattern. If you zoom in on the ECGs in either case, you can see that the QRS complex is excessively wide and that there are significant ST segment changes, including elevation and depression in many of these leads. Importantly, these ST segment changes, elevation and depression, are not due to acute myocardial infarction, but rather they are the new normal patterns for these altered patterns of conduction resulting from left bundle branch block and ventricular paced rhythms. A close-up basically of these two patterns demonstrating both the widened QRS complex and the ST depression and ST elevation typical of left bundle branch block pattern as well as ventricular pace pattern. These ST segment and T wave changes do not represent acute coronary syndrome. So, the absence of a widened QRS complex rules out bundle branch block and ventricular pace pattern. And, as we did with LVH, because we've ruled out these particular patterns, we've ruled out the presence of ST segment and T wave change that are related to these abnormalities. So, as of questions 1, 2, and 3, we have determined that ST elevation is present in at least 2 leads. In question 2, we've determined that this ST elevation is not related to LVH. In question 3, we have ruled out the presence of left bundle branch block and pace patterns as a cause of the ST elevation. So what's left? STEMI and several other non-STEMI patterns that can mimic the appearance of heart attack. So now we get to question 4, which is the icing on the cake. Question 4 asks us if ST depression is present in at least 1 lead. Remember, early in this discussion, we talked about reciprocal ST segment depression or reciprocal change. This is what we're dealing with in this question. So ST segment depression with coexisting ST elevation on other leads of the same ECG is termed reciprocal ST depression or reciprocal change. Why is this important to note? The presence of reciprocal change on an ECG provides very strong evidence that STEMI is in fact present. In other words, it helps you rule in STEMI in some of the more difficult cases. Here's a 12-lead electrocardiogram that we saw earlier that demonstrates ST elevation in the inferior leads, leads 2, 3, and AVF. We have a very obvious, in this case, inferior wall STEMI. Okay. If we look in lead AVL with the large arrow, we see ST segment depression. This ST segment depression is reciprocal change. While there's no doubt in this case that the ST elevation in leads 2, 3, and AVF is an inferior STEMI, the presence of this reciprocal ST depression gives us a very high degree of certainty that this ST elevation is in fact a heart attack. You can see the test characteristics up here on the slide. A specificity of 95% means it is a very powerful finding that would allow us to rule in heart attack. And we can see that the positive predictive value is 93%. This means how much faith can we put in this finding, and 93% faith is pretty high. Here's a 12-lead ECG that doesn't reproduce well. but basically shows some very subtle ST elevation in leads 1 and AVL that could be due to an early lateral STEMI. The ST segment depression in leads 2, 3, and AVF, which we have termed reciprocal change, is a very strong indicator that this ST elevation is in fact a STEMI, which it is. Here's a very subtle inferior STEMI with minimal elevation in leads 3 and AVF. The presence of this very subtle ST depression in leads 1 and AVL, which is reciprocal change, tells us again to a very high degree of certainty that the ST elevation in leads 3 and AVF are in fact due to an inferior wall STEMI. So, using this four-step algorithm, we have now determined that STEMI is likely if we have yes answers to all four questions. The 4 steps have confirmed the following. With question 1, the presence of ST elevation. With question 2, the absence of ST segment elevation related to common patterns that cause elevation, not related to infarction, including LVH, left and right bundle branch block, and ventricular pace patterns. With question 4, we confirm the presence of STEMI by noting the presence of reciprocal ST depression or reciprocal change. Now, there will be patients who do not meet the algorithmic criteria and still have STEMI diagnosed, but this will hopefully be detected later in the pre-hospital phase or after arrival in the emergency department. This algorithm is not designed to detect all STEMIs, but it is designed to detect most STEMIs. A stormy day on the lawn. So we can demonstrate a couple illustrative cases here to help you understand the process a bit